Okay. Oh, there he goes. So Ross is now in the meeting room. Okay. Cool. All right. So I believe that's everyone. Welcome to the fourth Think Before We Drink. We're going to be extending that conversation um, about clinical reasoning, and we're going to go more in depth with the envelope of function and the physical stress theory. So this is inspired by Erik, Meira, and J.W. Matheson's podcast on PT Inquest, and they were deliberately just going more in depth about the two principles and how that affects how we evaluate and treat our patients. So who here has listened to the podcast? Raise your hand. Okay, so yeah, just go ahead and just kind of share your thoughts. What you guys thought about the podcast episode? I thought the episode was very well done, and just the ideas that they brought up, and it really does make sense with how we should view musculoskeletal injuries.
I think it's just great for patient education. Whatever you teach them about envelope of function can carry over in the long run to help them take care of themselves. Just understanding like training volume, workload management, just things like that. Prioritize their recovery. And it's not just specifically just the tissue level, it's their overall health as well, their sleep, their weight. So I think it's a good job of just taking that into account.
Mm-hmm. Yeah, and I think I felt like it gave a better, not just like a clear meaning, but it definitely gave you a better visualization of how to really optimize workload and being able to apply the right amount of stress in order to create an adaptation, but not to the point where you would cause injury. And I think just that visualization with the graph and that area that was shaded um, with with that envelope of function, I thought that was really helpful too for any clinician. But I do have a question for you guys. What do you guys think about, or do you guys ever go over the envelope of function in your physical therapy curriculum as a student or athletic training?
I wouldn't say it was as big of an emphasis as it should be. I feel like PT school is a lot of looking at impairments and then looking at their function, all these different categories, but never bringing it all together as like a combination of factors to manipulate during the rehab, whether to reduce stress or put more stress in certain areas.
Right.
Yeah, I would agree with that. Obviously, us going to school at varying times, but kind of still within the 10-year range of each other. I think, yeah, PT school breaks it down very well. But what was nice about both these articles and the podcast was it provides like the framework and the language, right? Sometimes, like, especially early on in my career, I felt like a lot of patients were like, well, what's wrong with me? Like, what is it, my disc? Is it this? Is it this? And this kind of takes it away from identifying like a specific structure and looking for that one thing that patients are trying to cling on and give them a bigger picture. Right.
Yeah.
And so I feel like that was very helpful in terms of like keeping my framework when working with different patients, like what can they tolerate now, how do we get them to that next level, when did we push it too much, and so kind of working within those. Right.
Yeah, I would say definitely in athletic training school there was definitely no mention of envelope of function. I think we've always followed some sort of system to really figure out what the impairment is or what our differential diagnoses could be, and go over a list of different interventions that we could use to correct the impairment or treat the injury per se. So but having the envelope of function and the physical stress theory, I think it really clears up how we would educate the patient. And I wish we learned about this in school. Then that way, like a lot of the questions that we would have would have been answered, and it would be a lot easier for us to really teach our patients as students and kind of get that firsthand experience of just knowing like how do I explain something is how do I explain what exactly is going on in that structure without making it seem like without making it too complicated, right? I felt like a lot of these different biomechanical terms have they kind of simplified it for us, and it's definitely something that was once I learned about this, I thought it was really easy for me to it was a lot easier for me to explain these to high school student athletes and parents, and they would always go to the WebMD. It's like, oh, I have pain right here. These are the list of things that could possibly happen at my low back or at my knee. Like, oh, there might be a tumor. It's like, well, no, this is WebMD. That doesn't it doesn't make sense, right? So yeah, I really appreciated both principles for sure.
Can you guys hear me?
Yes.
Does it sound weird?
No, it sounds very real. We can.
It just sounds like you're in your car.
Yeah.
So it sounds like
I'm zooming in,
like a garbage can or something like that.
Right.
So the article's like the original envelope function is 94, right?
I believe so. Yeah, it's somewhere in the
96.
Yeah.
96. Okay. So like I graduated in 97, and the first time I'd really heard of it was working with Rob Neighbor in probably the early 2000s, somewhere in that ballpark. And he would kind of refer to it a little bit, but I think where Rob really kind of utilized Dr. Dye's reference to it was more about the probing of the knee without any sort of anesthesia. So I think that was kind of an interesting kind of dialogue break into Dr. Dye, where I really got to understand the whole concept of the envelope function was when Dr. Dye actually was a guest lecturer at TCC, and he did his whole thing on the envelope function with ACL rehab, and he was a hard proponent that athletes, if you look at their MRIs serially through 2 years after surgery, that the tunnels don't look right. There's still like edema in the bone. There's still swelling. There's still irritation of the synovium, all this other stuff. So his whole take was they shouldn't be going back to sports till 2 years. And I don't know about you, but you can imagine like the uproar that created in a conference of 200 PTs and dual credential PTs and ATs and all this other stuff. But when you start looking at the MR studies, it makes sense, right? Physiologically, but it doesn't make sense in terms of the reality of sports. So I think that was kind of one of those things that I think it was really interesting that but he's very hardcore. Like, so I don't know. Do you feel that comes through in the article? Like how strong his opinion is on that at all? Curious.
I don't think so, because he's talking about the knee as a whole and not specifically ACL surgery. I mean, he does talk about it a little bit, but yeah, I don't feel that sense of urgency in his writing.
Yeah, I think that's kind of where it was kind of surprising to hear him in person versus like in writing. Like he just seemed much more passionate, I should say, in person than what you kind of get across reading it.
Yeah.
Which just kind of I don't know. I mean, that's good. Maybe that was also different because that was closer to 2000. Shoot, I don't even remember when that was. More like 2008 compared to 2001, or 96. I mean, that's a big jump in years. So he may have had a different perspective on it.
Is that when was the accelerated rehab really a big
94.
Thing? Oh, 94.
90,
okay.
94. 92 to 94. So all the Mark DiCarlo shell-borne articles were all accelerated in the early 90s.
Okay.
So he came out with this like completely in the face of all that, right? So I think it was great because it definitely slowed everything down. And I do like the way JW and Erik kind of mentioned it, is that's really kind of our goal, is to put them in that optimal loading zone, right? And it doesn't really matter what tissue you're stressing, but I think that's where it starts going into where Rob tries to teach a little bit more about every tissue has a specific tolerance. So that is the skill of what we're trying to do, is the dosage, right? So I don't know. I think it ties in very, very well, and I like the way he explains it, and it makes sense with Wolff's Law and all those different things. So, but I love the fact that JW and them, they're pretty hardcore in terms of newer articles, but then they kind of go back to this guy who's been around for a long time. So, cool stuff. But yeah, I'm still driving stuff, by the way.
Yeah, I feel like what's really valuable about these articles is that it still holds ground to this day. I mean, we would always hear about, even with like the pro athletes that may come out earlier than their anticipated rehab timeline dictates, then and people are still trying to return to play earlier than is what's suggested, because they always hear about these different stories about, oh, like so and so can get back to return to play really soon, but this kind of provides that resource to educate our patients and knowing like, hey, like not everyone can be like Adrian Peterson, not everyone can be like RG3. It's still like, I feel like this still holds true to all the rehab that we do, and being able to communicate with our patients in this manner, it really helps out a lot.
Yeah, and I think like, even though like these are older, right? These concepts, these articles are older. Like if you even think about like now, more recently, people focusing more research and energy on strength deficits, limb symmetry index, and how it's not exactly, I mean, yeah, you want to try to get within 90 to 100% of the uninjured side, but all this research is saying that the uninjured side actually gets weaker, right? Because that envelope, and it's the same concept, right? That envelope of function, even on that uninjured side, has dropped because they're not at that same level, right? So if it could even be applied to the newer stuff that is coming out now.
Right. Abdul, what are your thoughts?
So for us at Mount St. Mary's, we had a third orthopedic class. So typically, from some other students that I talked to, they get two. We had 2.5 years of orthopedics to some degree, and then our last course was an advanced orthopedics class, which was taught primarily by two fellows from WashU in St. Louis. So we were kind of lucky to have that, but they did introduce this topic to a degree, which every time I look at this, it kind of gives me a little bit of a flashback to what they were saying, because this is a difficult kind of concept, especially like you guys said, we were very impairment and like what is structurally wrong with whatever we're looking at base. That's how a lot of what we were taught. And then this advanced orthopedics class kind of was like, hey, forget everything you learned in orthopedics so far, because this is going to be pretty different. And then they briefly, I mean, they didn't use this exact terminology, which was interesting, but it's kind of falls within this realm of treatment. So I don't know. I feel like I had kind of a little bit of an introduction, but I mean, again, that class was a little difficult because we just came from typical traditional orthopedics to jump into this kind of new mystical, like how to think about things a little bit differently. And so, yeah, for me, this is going to be a very, I'm going to absorb as much as I can over the next year, for sure.
Right. What do you guys think about like the physical stress theory?
I thought it was neat because it was from a physical therapist's perspective. Like Dr. Dye was a orthopedic surgeon or orthopedist. And so the Mueller article took it more from the rehab side, and then also, but said it's applicable across all the specialties of physical therapy, right? Like wound care, cardio, pulmonary PT, neuro, right? And that it's transferable across diagnoses, no matter if it's orthopedic related versus non-orthopedic. So I thought that was pretty cool. But yeah, I mean, there was a lot of premises that table one was like, whoa. So I feel like it was just a very, very detailed version of what Dr. Dye was saying. Like he broke it down so much.
Yeah,
Maybe
it
a little
almost looked
too
like
much.
it was like the 10 or 12 commandments, but for physical tissue. Like it was just like, oh, you gotta follow these rules.
Yeah.
And I think I mean I definitely procrastinated on reading this article, but it was like just like how Scott Dye had his article. I think what was really cool is just having some sort of foundation just laid down, and being able to state that this is what happens to tissue when you have a lot of stress, if you have the right amount of stress, and then what happens to the tissue too. I think it's just important to know that, I mean, it could get smaller, it could get bigger, but there could also be death, things like that. And I think it was just clear to really understand that.
Yeah, I liked exactly what you kind of just piggybacking off what you said, but like in Dr. Dye's article, he has like the zone of super physiological overload, right?
Right.
But it's like, what does that mean? Does that mean that's too much? Does that mean it's too, like, and then it goes to injury, right? Whereas like, I feel like in Mueller's, he like said, this is like the hypertrophy, right? So this is kind of like the zone you want to be in, I
Right.
guess. And so I felt like it was a lot more, by breaking it down into 5 instead of like 3, I guess, it like made it a little bit more clear.
Right.
But
Yeah. And I think what made me just kind of, I thought like, I was trying to think of like what would be lacking of this article. Like maybe there should have been some numbers, or like what is considered supraphysiological load, or how much, or what's considered too little. Like how are we lacking in, or how do we know if we're lacking in stress? But I think that's really the idea of the article, right? It's everyone is different in how they respond to stress. And I think what's after so just right before this Think and Drink session, we had Kevin Wilk put up a recovery seminar, and I think the theme around recovery in itself, it's really different for everyone. Everyone's gonna want to everyone has a preferred intervention that makes them feel good, and I think that's just kind of, I feel like that's relatable to what we're talking about now with the envelope of function and the physical stress theory. But it's cool that now there's going to be more research about putting numbers to those recovery interventions, and seeing like if we did this much of, let's say, like Normatec, does that have any adaptation, or any sort of effect to the patient, things like that, or even just nutrition wise, like as how does that affect our recovery timeline? And I think that's I think as now that we're getting more into emphasizing recovery as a theme for performance, I'm really curious as to what the future research holds and how that's going to change sports performance, and what's the new trend that's going to be coming out.
One realization I came to, actually, now that you kind of brought that up, was over the last 2.5 weeks, I've kind of joined a bunch of these webinars, these free webinars that are being posted all the time. Everyone's giving out some great content. And one topic I feel like that is brought over like over and over and over again as it relates to like kind of athletic training and sports PT and that kind of stuff is understanding the concepts of strength and conditioning. And I never really understood what that meant until I started kind of doing my own research and looking at some of the stuff that you guys have been sending. And I think it kind of clicked because I had some of the questions that you were having, Phil, where I was like, okay, can we quantify this to make it easier? Because I just graduated in October and everything was pretty much like formed out for us. I think Ross mentioned this last time too, where it was like, as a new grad, we just want, hey, it's 7 repetitions and that's the answer. You know what I mean? Like, so just trying to quantify everything and kind of make things easier in my head. And then that realization that I came to, which was like, you really, really do have to understand strength and conditioning to understand how to like better assess and help and treat and do all the things that you want to do with your patients.
Yeah, I definitely agree. And I think the one thing that kind of just kind of sticks to my mind is, I know definitely at my program at Cal Baptist, we always emphasize on taking patient outcomes. And I think that's what kind of drives our practice forward, and seeing if our interventions actually work. And I think what's good is just to see how we can achieve these patient outcomes. And there's going to be so many research, whether if it's conflicting or agreeing with each other, future clinicians, or even current and future clinicians, they'll be able to see the different interventions and what methods actually do work and what doesn't work, and being able to rely on clinician and patient preference from there to drive evidence-based practice. So I think even with all these theories that come around, I think what kind of gives our responsibility is being able to reflect on what we do. And I think that's definitely important in our practice.
I'm going to jump on kind of what Jendo was saying. So basically to me, the physical stress theory is adding in a couple more domains than just kind of what more that biomechanical approach to applying it to Dr. Dye kind of goes into. I mean, they're a little bit better with adding in psychosocial type things, integumentary type stuff, things like that, which I would say we really haven't gone into as in depth. Would you agree with that? So we've always kind of done more just the basic woo stuff, right? So that's ligament, cartilage, bone, tendon, musculotendinous type stuff. So I think this is like, to me, it was much more all encompassing in terms of the bigger picture. My question would be, is it easier to understand, or is it harder to understand when you start going more all encompassing? I don't know. What are your guys' thoughts on it after reading it?
I'll go. I think it was both. I'm always in the middle. I can never choose a side. I think it was both, just because, the whole biopsychosocial model of the patient has all these psychosocial factors that could be playing into their pain and their recovery. And so you need to take all those things into account. But if you have someone who's more type A, just wants the facts, then just using like Dye's model, like breaking it down to bare bones like that, then you use that. or is someone here, what's going on, needs to talk it through more, then you start to consider those other factors. So I think it was helpful that they acknowledge that all those other factors exist, and they, like they said in the article, they're not going to go into detail about it, but know that it does play a factor. But the bare bones of it, the Scott Dye stuff, the envelope of function, that is like foundational, right? And that can explain biomechanically straightforward, like why this tissue isn't tolerating what you would want it to tolerate.
Now, I think that's a great concept, because I do think dyes is a little bit more black and, I don't want to say black and white, but I think it's just a little bit more kind of compact. But then moving towards the strength conditioning, I think that kind of goes back to that whole concept of hypertrophy, atrophy, or kind of that perfect state, right? So I think one of the things that I do think that separates a lot of the therapists that do very, very well in orthopedics to being able to get people to a higher function is being able to determine that load, like being able to push people a little bit harder. Where I think that has gotten a little bit watered down in the last few years is sports performance has become the focus of what rehab is for a lot of people that are looking into the sports world. So it starts to kind of almost jump to more almost the personal training, strength coach type of stuff. So a lot of the training is not as manual. It's much more systems based, like saying, okay, well, I need to address a mobility deficit and a strength deficit and a da-da-da-da. And I think that kind of has taken some of this thinking away, because I think this type of thinking is really the foundation of what we really do. And I think that, unfortunately, a lot of the newer concepts of performance enhancement and the training, yes, although it does help to be to understand exercise physiology and the stress theories of behind strength and conditioning, things like that. But the reality is being able to pull it back and knowing when to turn it on and turn it off, right? And knowing when to apply it and when to push it. And I think that's the part that takes a few years of experience and a few years of seeing patients doing really well and patients that don't do very well, and being able to figure that out. One of again, I'm going to kind of go into this conversation I thought was really fascinating and was actually a couple of weeks ago with Paul Christensen, was that he was interviewing some of his aides that are going to PT school. And he asked them, what do you think of becoming a physical therapist is really going to be? And a few of them were like, well, it's kind of like a personal trainer with more experience. And he was kind of like, whoa, right? And then it was like, well, it's kind of like being, if you go into sports, it's being like, someone who gets to do these really, high level type of things. And I think that's where, unfortunately, it's getting mixed up. And so I've mentioned this to, I know Jendo's heard me say this, especially at the high school level, I think you can apply a lot more of the information that you learn, like whether it's the acute care of the athletic training, the strength conditioning, to the end stages of rehab for a youth athlete, and also managing the traditional rehab between what we see in the clinic. So that's the kind of stage 2 to stage 4, which is what we see in the clinic typically, where as an athletic trainer, you get to see more 1 and 5, right? At the beginning and at the end. And so to that point, I think that a lot of times we have really the goal, like, so it seems like PTs kind of want to do what the ATs are doing, but then the ATs kind of want to do what the PTs are doing. And I think that's a little bit of where there's this little bit of confusion of these battles. Now, and then there's the strength coaches that are doing the very end stages when they're dealing with either a healthy athlete or a fully rehabbed athlete. Now, once you get to the collegiate level, maybe a junior college level, there's no real PTs involved unless they send them out. So the ATs do pretty much everything. They do even the strength conditioning and the off-season training, et cetera, et cetera. But then when you get higher college level, there's a distinct delineation between the ATs, the PTs, and the strength coaches. So even if I'm a CSCS, I don't really being a strength coach at the collegiate level, or even especially at the professional level. But I still have to understand it of how that applies to the athlete that we all might be dealing with. And I honestly think that's where PTs really get into trouble, is when they do have a CSCS, or they do have an SCS, or they do have the AT, is they overstep those boundaries. And depending on the situation or scenario you're in, you definitely need to be kind of staying within your lanes, or you will be quickly shown the door. And I think that's something that is not always talked about when we're kind of thinking about, you know, what's going on in terms of the sports world and how that always works. And so, but I think the benefit to being a CSCS, the benefit to having an SCS or an AT, as well as being a PT, is understanding what each of those rules are and knowing what each domain will do. And so then you're okay with going, okay, you guys are doing this, I'll do this, you guys are doing this. And I think that creates that team, right? And I think also a lot of times PTs, especially in private practice, want to do it all. And I don't think that doesn't go well, especially when you're dealing with team chemistry, team atmospheres, and things like that. So I don't know, just my 2 cents. So cool.
Yeah, I definitely agree. And I think now we're seeing a lot of strength coaches trying to do some manual therapy in some shape or form. And I think that's just, to me, I definitely have a problem with that, just because they're not qualified to really do those kinds of interventions on their clients or our patients. And I think there has to be some sort of fine line that could delineate all the professions, really. I think everyone just wants to kind of dabble in on different things. Yeah, and even with like the athletic training profession, it feels like we're even trying to do as like everything, and just trying to be exposed to everything, and feeling like really the jack of all trades but master of none kind of deal. But yeah, I feel like all 3 professions are just kind of like, I feel like if we kept learning from everyone and everything, I wouldn't be surprised if they all just became one huge profession in the next 20 or 30 years. If there was no sort of, someone throws down the hammer and just says, hey, like, let's kind of make sure that we stay in our lane, but at least we can all communicate with each other and know whose role is what.
So to your point, Phil, is I think that was one of the great conversations I had with Potenza early on. Was he originally started to be an AT in school, and then kind of was directed towards becoming more of a strength coach by Mike Boyle. And I don't know if you know, but Mike Boyle's an AT, but not a CSCS.
I heard the story, yeah.
Yeah, so the kind of one of those things that he kind of directed him in that way, because he felt that he would have actually a better career with helping people and actually making more money, et cetera, et cetera. So one of the first things that I learned from Mike was he really wanted the physical therapy to focus on soft tissue play, scar tissue, joint mobility, range of motion. That's what he wanted out of physical therapy. So you might see, like, if I'm working with the Sharks guys, I don't do a lot of the strength conditioning unless they are not available. Like, they can't do it, or they aren't around, like on the road or something like that. But if they're there, I don't do that. I don't go there because that is their role. But from the get-go, that's what was discussed, is this is what we need. So therefore, if you can get these guys tissue prepped, so therefore they can recover from the workouts we put them through, or they have the adequate range of motion to do a particular thing, or they have adequate load tolerance to be able to do something. That was really kind of the agreement, right? So I think that again, that if we understand those roles and the communication is really good amongst the people you are working with, I think it works really well. And now I think, you know, one of the things that I see with San Jose State is that there are a couple people there that really do really want to involve everyone in the team. And I think that's why the mindset's there. The structure just isn't quite there yet. You know, I mean, I think if it comes from extremely high up with the ADs, all that kind of stuff, I think it could be very, very good. But I think it's been a little bit kind of discombobulated, but it can get there. It definitely can. So, but I think kind of to your point, Phil, was I think as long as people can work all together and they do work well together, they kind of can cross over a little bit, right? But where they cross over is more in the understanding of what each other does, and that builds on that mutual respect, right? So then each person has a part in that team and they can continue to build on it. Going back to the Mueller article, so he's reference 122. I don't know if you guys knew. Yeah, so he kind of does go back in there and kind of dig into that, which is really cool. So I think Mueller and Malouf did a really good job on this. That is the way I say it, right? Malouf. Yeah. So good
Malouf.
stuff.
I just wanted to say one thing, kind of
Yeah.
going with what you guys are saying, is I think that as a new grad PT, one thing that we have seen, and you've mentioned this before, Ross, too, is the Instagram PTs. I think that they heavily influence a lot of kind of the new kind of generation of PTs. And I think that everybody's trying to be an Instagram PT now. And it was funny because when I first saw this kind of stuff, when a couple of my classmates started an Instagram PT page too, I went up to one of my orthopedic professor and I was like, how do you think that doing things like this and how popular this has gone is going to damage our profession? And he was like, between me and you, I think it's a terrible idea, because then exactly like you guys said, we move so far away from, as PTs, so far away from the core of what we do, and now like we're encroaching on so many other different professions, and like you guys are saying, I mean, you guys have something very unique here. I'll tell you guys, like, I've never seen a clinic that has ATs, PTs, aides, everything all kind of working in unison together. I've never seen that before. And when I have, it's like there's always one piece missing. It's never everyone together. So I just to comment on that is, yeah, like I think there's value in these Instagram PTs or strength and conditioning coaches and things like that. But I think it's just a dangerous image that we're painting newer grad PTs that, hey, you can do this too. All you have to do is do a piriformis stretch if your back hurts, and then boom, you have a bunch of followers that you can, I don't know.
Well, Abdul, I'm gonna play the devil's advocate here though. So nailed it. You're right on, and I think I would agree with you 100%. Now, there's two guys that are on Instagram that I think do a phenomenal job of educating people. One of which is Mike Reinold, okay? And partly because he breaks things down into special tests, to different techniques, to different treatments, to different training methodologies, things like that. The second person I think is really, really good with that is actually Kevin Wilk. The problem with what Kevin does is he has mostly sexy exercises on there. And you and I know that if you kind of do rehab for a while, it gets kind of boring. Like the basic stuff gets pretty boring. Once you get range of motion, once you start strengthening, it's pretty damn boring. So I think that when you do see some really cool things that are involving bands and boards and foam and, all these, the little, what do you call it? The red donger thing and all this other stuff. I mean, it's like, it's cool looking, right? So it automatically draws you to it. But I think what I always kind of try and go back to is you have to go back and think about what is the goal of what he's actually doing, right? Where are they and what phase they're in their rehab? What is the outcome he's shooting for? And I think when you look at it that way, it's very meaningful. But when you just see it like a video and take it for a video for all it's worth, it's very attractive. It's like, whoa, that's so cool, right? I want to do that too, right? I like that. But I think when you start thinking of it as, I guess that's what I would challenge you guys, right? Is to be able to really think it through. Like, what are they really trying to challenge? What phase do you think they're in their rehab? What is the end outcome, and why is he trying to go after that particular method of training? And I think that makes more sense to you then it won't be just like something that's cool and this is the latest thing to do. So I think that's why, you know, like I said, I think Kevin shows some really cool exercises and some amazing perturbations using, you know, balance board and all this other stuff. But I think it goes back to the basics of what's the goal, what are you trying to do, and why and when. I also just noticed 124 is Rothstein, right? The hypothesis-oriented algorithm. So that's the other article that we kind of hound on you guys. So it's kind of cool. I think these are phenomenal, you know, examples of exactly what you're going after, Phil. Is to just kind of say, hey, you know, how do we think, and how do we decide on what we're doing? So pretty cool stuff.
Well, Ross, what did you feel like when I think I know you touched upon this before, but when you were first learning all these different principles when they were coming out, and Rob Neighbor was kind of teaching you these concepts, like how were you feeling as a young professional coming out of PT school?
Well, you know, it's funny because there was a couple turning point moments for me. I think one was I felt really fortunate going through PT school as being an athletic trainer and actually working for 2 years at the time Pac-10 level and literally being forced to figure stuff out on your own. And that means going on road trips for 5-6 days, you know, being stuck in the dorms for all of football camp, and, you know, but having some really, really veteran ATs around that you could ask. So by the time I went to PT school, I think that really helped in terms of the basic orthopedic stuff. But once I got out, I think, you know, I may have mentioned this to you guys before, but, you know, like when I got done, it's like a hot day in Stockton, you know, I think it was my birthday too, I think, when I graduated from PT school, because it was right around Memorial Day weekend. And I was thinking I'm pretty cool, you know, I got my master's, done with PT school, ready to go, you know, go to Hawaii for a week or something, you know, go celebrate. And, you know, my dad's sitting there, and I can distinctly remember the tie he was wearing and the suit he was wearing. And he's kind of just, you know, kind of nodding his head. And I go up to him and he goes, "Congratulations." I'm like, "Thanks." And he goes, "So what are you going to do now?" And I was kind of like, "I don't know. Why? What does it matter?" He goes, "Well, you aren't going to know, you know, you aren't going to know anything. You aren't going to know shit for 5 years." And I was kind of like, why are you telling me that right now? Like just after I got my diploma. But that was the foundation, right? So you kind of already knew, kind of coming from your like pedestal of being like, gosh, we got all this information from PT school, back to like, you know, wait, why did you just say that? You know, so I don't know if that's an Asian thing, you know, to like bring you back to earth a little bit, you know, when you're feeling, you know, all hot and everything like that. But I think that really kind of set the stage, because then it was, okay, then what do I need to do to learn? And, you know, and then, like you said, working with Rob, you know, honestly, you know, working with Rob was pretty stressful, because, you know, he demands a lot out of you. He challenges the way you think. He challenges whether or not, you know, the perception of being smart is real or not. So I think that's one of those things. But the bottom line is, when people that you're surrounded by early in your career, the bar is set high, you don't want to do anything to disappoint them. So you're always going to be, okay, what do I need to do? What do I need to do? What do I need to do? I think the nice part for me was that my dad had a very different thought process. He's a little bit more like Bill, which can be a little bit more, you know, a little bit more vague, a little bit more ambiguous, but there's obviously a very, very thorough thought process behind it. I just couldn't understand it as well, to where Rob was a little bit more logical and would give you a little bit more, here's this and here's this, and this makes sense, this doesn't. I remember the example of bone bending, right? There's in the osteopathic terms, you know, everything is based on C1 being rotated or the sacrum being rotated. And if there's any rotation of C1 and the sacrum, then their whole system's off, right? That screws up the craniosacral rhythms and they can have bone bending, right? Well, what the hell is bone bending, right? And I remember Rob saying that to me, like, I don't buy it. Bones don't bend. If they bend, they break, right? So there's got to be something that we have to be able to understand. So I think that's kind of where that was helpful. The other thing that I found was based on people like Rob, Bill, my dad, Richard Jackson, a few of them, they were very good at pointing out people to go listen to. If you ever have that chance, go and listen to this person speak. Don't just listen to them on, maybe a podcast or something like that. Go listen to them present in front of an organization and see how they actually talk. And I think that was one of the things that really, really helped, because you want to go listen to a Stanley Parrish. You want to go listen to an Olaf Avianth. You want to go listen to a, Richard Jackson, for that matter. You want to go listen to George Davies. Those are the people that you should learn from. Whether you learn anything from or not, you're going to get something. So I think that was one of those things that was really helpful early on too. So I don't know, long story short, but yeah. So
yeah, no, that was great to share. I feel like, yeah, just definitely coming out of AT school, there's definitely that feeling of like, oh, I can do all things, and we learn all these manual therapy techniques. I mean, that was like the hot trend for athletic trainers, just knowing like, oh, have you heard of Mulligan MWMs? Like, this is like a gem, and you can fix apparent meniscal lesions with these tibial internal rotations. Like, this is great. And then you want to like try it, and then all of a sudden, you're in a setting where it's like you try all these MWMs, and then all of a sudden you realize, oh, I forgot how to actually talk to someone and learn their story and figure out what got them into this current state, and just being able to get the actual information and kind of think things through, rather than just like picking out a system and picking out an intervention. And I just feel like I wish like every profession got to, like, they're all exposed, I feel like, or in their schooling, like these two articles could kind of serve as that foundation in their curriculum, and just knowing like, this is how the body works, and it's up to us to figure out where do we lie in those different for these different theories and principles. Like, what can we do to enhance human performance, or being able to get someone back from an injury? Like, where does our profession lie? And being able to understand that everyone plays a part in the envelope of function, or in the physical stress theory.
totally agree with you, Phil. I think that's one of those things that I think when you get out into the working world, though, is the reality is it's like just churn and burn, man. Right. It's like see patients and keep your head above water. And that is unfortunately the reality to most of the beginning of our careers, right? So then you're trying to just get through your day without drowning, and then you've got paperwork, and then you're trying to learn about how to be a better therapist. And so I think that is one of those things that, and I've emphasized this to Dexter. I've said this to even Abdul to a certain degree. Is part of that is sometimes it's good to see that, to feel that, to be like underwater, barely being able to tread, and then being able to step back after a year or two and go, wait a minute, there's got to be something more to this. Because I will say the number one thing that I have learned from almost all of those big iconic PTs that I mentioned to you is they all kind of had that same moment where they were practicing for a year or two and they were all disenchanted with the profession. They were just like, there's got to be more to it. This doesn't make sense. I don't feel that being a good PT is just the modality I select. It's not about choosing ultrasound or stim or using auto traction or this kind of stuff. And so that's what pursued them to search for something more, and then to learn from the different thinking processes and stuff like that. So I think that's one of the things that has been pretty common across the board, is they all kind of felt like this is jacked up. Like, this sucks. It's not like what you thought it was going to be. So I think that's kind of one of the things just kind of keep in your mind, I guess. Cool.
Yeah. Paco, do you want to share some thoughts? I know you haven't really said much, but yeah. What do you think about all of this so far?
Well, I've been just soaking in all the knowledge. Well, one thing I want to say, I basically agree with everyone. Well, duh. But I think what I wish
you can disagree.
we had,
That's okay.
There's a huge gap between what we learn in school and what actually our job is in terms of like, I really wish we learned anything about clinical reasoning or the envelope of function in school, but we didn't. So it's as kind of Ross said, that it's kind of like head above water, keeping your head above water, like in your first few years of either PT or I think ATC too, and just trying to like do better than you did yesterday, I guess. But yeah, it's yeah, I don't know. I feel like everything else was said already. It's really interesting to learn how different types of patients can affect your entire rehab process and all that. So to me, that's one of the biggest thing taking out of these. Well, I didn't read the articles because I couldn't find one of them, but in the from the podcast, I could only find the Miller one, which I liked, but it was very dense and I mean it did help me grasp the big picture with all those like little details. I think it does make you think like, oh, what does make you think of the whys and why the psychosocial component is so important in patient care and all that, and when to use it and when not to use that, as Jendo was kind of saying. But yeah, that's basically what my takeaways were. And sorry, I had to be on a phone call for a couple of minutes too, so.
All good.
Just San Jose State things, you know.
Yeah, San Jose State.
Oh, and then one more thing that I know, well, when I was an athlete at San Jose State, I know that there's a lot of strength and conditioning coaches who used to think that there's no lines in between those two professions, athletic training and strength and conditioning. So I think it's the matter of like knowing where your professional line stops, kind of. And like you can do stuff, you can advise athletes to like foam roll and do this, do that, like manual therapy, but I think it's a matter of them understanding that that's not their job. They can advise it, but that's not their job. And I think communication between strength and conditioning specialists and ATCs or PTs are going to be crucial in keeping those lines and kind of not overstepping those boundaries.
Right. Yeah, I think what everyone just kind of brought up and what made me think about is what so Steve Bartlinski, he would talk about how they would used to manage someone's rehab and their return to play, and they would use what's called an active integration program. So what they would do is the athletic trainer, the physician, and the strength coach would all kind of sit together, and they would have a spreadsheet, and they would go through the phases of rehab and figuring out what goals need to be achieved and who would be responsible for achieving those goals. So they would have their initials right next to each goal. And so once that plan is made, they would all kind of sit around together, they would review the plan, and then they would each initial it. And so after each phase, especially like the early phases, I mean, they had the AT, the physical therapist, the physician, and the strength coach, and they would all whoever was in charge of that phase or that goal, they would just initial it right after, and then they would communicate with the next professional and saying, hey, like this is what's going on. Or if they had like a setback, what do we need to do? We need to revise the plan, come back together, and go through the plan again, and making sure that they kind of dotted their I's and crossed their T's, and making sure that they didn't put their patient in danger. So I think that's something that, I mean, in an ideal world, if we could do that for the high school setting, I mean, that'd be something else. But yeah, I really liked what when Steve was telling me about this, like what they used to do at Stanford, and I wanted to teach that to the high schools, to the high school students at Fremont High School, and saying like, hey, like there you can learn so many different roles in sports medicine, and it just really depends on what you're really interested in, and this is how you would work as a team. And I think that's what and and I think that's what's great about the healthcare profession and moving into more of that teamed approach and going from there. So yeah, that's what when you guys were talking about, when we were all talking about how there should be lines drawn and things like that, I think that was definitely, it just made me remember about what they usually do at Stanford. And I thought that was something that should be shared. Hopefully, like everyone can follow that model.
Phil, to your point on that, I think one of the things you got to remember with that is when you have 3 or 4 people, whether it's a physician, an AT, a strength coach, and a PT, that can work well together and that respect each other really well, you kind of almost have to catch that like lightning in a bottle. You kind of have to, enjoy it when it's there, because unfortunately the reality is it doesn't always gel like that. And I think that's kind of one of those things, and you can see what happened to Stanford after him and I'm blanking on his name, strength coach. Jeez.
Scott. No. I know who you're talking about. I know who you're talking about. Yeah.
I can picture him. I know his. Oh, Jesus, it's gonna kill me. So yeah. So basically, but I mean, that's one of those things and I think it takes a couple people to kind of set that standard, and then kind of being able to create those lines of trust. Really is really what it comes down to know that every person is in this for the betterment of the athlete, and that it's not for individual egos, it's not for individual gain or things like that. I think that's something that 100% I hope that any of our graduates from our residency program understand, is that it kind of goes back to me saying that if the resident's on your sideline, it's your sideline. So you're the one that's going to be directing what do they need to do, what do they need to understand, and then you've got to set up that position for them, right? As opposed to them coming out and being in charge. No, it doesn't work like that, right? And I think as long as people are aware of that kind of stuff, it works very, very well. And then the mutual lines of respect kind of start to work in well together. So yeah, but I guess that's one of those things that if you can get that situation, you want to cherish it, because those things don't always happen. And I think that in professional sports organizations, I think when you see it is when organizations win. And people may not always like each other, but they respect each other, and they know what each can bring to the table, and they're able to work well together. I think that's kind of one of those things that we're always striving for. We're all trying to find that whole thing going. I get it. Abdul, total side note, dude. You usually wear a hat, don't you?
Yeah, when I'm not working, I like wearing hats.
That's why Phil noticed your hair the other day, and we just never noticed it before.
Oh, yeah.
Damn, dude. So it's like you and Dexter are kind of doing the whole hairstyle competition right now, dude.
I can't compete. He has a beautiful mane. I'm not there yet.
Beautiful mane.
Wow,
it's not a competition, but they
bring it, dude. Who can get the bigger man bun going on there, dude?
Should have kept growing yours, Ross. You could have competed with them.
I haven't cut anything off the top yet.
Oh, okay.
Only I
you got to bring back the mullet.
You just cut
the mullet,
man,
the man bun, and then Abdul's hairstyle.
The mullet just has too many references to the 80s that I just can't do. It's too long ago, man. So
to touch on what you were saying, Ross, just one last thing. I know we're going over time, but at CSM, I went to that interdisciplinary care and D1 sports talk. And one of I think she was an MD actually. She started from the ground up at University of Utah, I believe it was. But she started with a team of just like 2 people who were like interested in like, hey, how can we make this care better for the athletes? How can we improve communication? And when I talked to her on the side after, I was like, man, how long did that take you guys? And she said it took years, because it was not only just like finding the right people, like you said, that work well together, but like getting everyone to get that communication. and I asked her if she had any advice for me in trying to like start some communication stuff at San Jose State. And she said, just keep trying. And I'm like, okay.
Yeah, it's
But
I
yeah,
feel like
so
it's
it's not
the
just
culture
just
thing.
like it's finding the right people that
Yeah.
work well. Yeah, it's totally a culture thing, and
Definitely a culture thing.
it takes a ton of time, and people that are passionate and committed to it. So
Yeah.
it's not a quick thing.
Yeah.
For sure.
I know, I feel like today's session definitely drifted from like the science of it, and then all of a sudden we talked a lot about the profession and,
Yeah.
and that interprofessional collaboration. I do want to end it on more of a science note, and this question goes for Paka, because I was always I kind of had this question in the back of my head, and then as we all kind of like got into that question, I know Paka, but you're gonna kind of end it on just a random question, but so considering like the envelope of function and everything like that, like how do you feel like, so synchronized swimmers, they always feel they're very flexible and things like that. Like how do you figure out your dosage? Like what's your kind of thinking behind like if you're pushing them way too hard, or if you're not doing enough? Like what's your thought process on that?
In terms of like rehabbing an injury or more of a strength
Both. Yeah.
performance
Go with whichever.
base?
Yeah.
Well, since I've been working with them consistently, it's been easier to progress from like very base strength stuff to more strength with flexibility. So, I mean, I haven't really had to take back a lot with them, so I can't really answer the top threshold part of that question, but I did realize that there were a lot of times in the beginning of when I started working with them that I wasn't aware of how strong they are.
Mm-hmm.
So I think for me it was more of watching them at practice as well, not just in our strength what was it? Not in our strength workout. So maybe I did a strength workout with them, and then I watched them at practice and like realized that, oh shoot, they're like lifting each other up and they're like 80, 90 pounds. So like that's when I knew that I need to like bump up my strength workouts and all that. So it was more of that.
That felt more like an eye opener to you to kind of I can actually push them a little more.
Yeah, the top threshold I don't think I pushed them too much. I think that's more of on the coaches aspect, and that's when I need to tell them to back off. So I think they're more likely to do that at this stage where we are right now.
Got it. Yeah, I was always curious because it's like you see someone that's like you see an individual with a lot of flexibility, but like the first thing it's like, oh, like I don't know if I need to push more of like the strength component. Like I can't tell, but if we could kind of see like what their performance is like and what they actually do for their activity, then it kind of gives us a better sense. And it took
me at least 6 months to understand the flexibility component and to really understand what is good flexibility, what is not good flexibility, and what could hurt them in the future, and what is like more so to their advantage. Like there were girls that their flexibility was on point, but they had no base strength, and that's when I knew that like we need to start with that, because that's why I keep telling them that you can use your momentum and you can use your flexibility, which everyone could have. You just have to work on your splits and all that. But if you don't have the power and strength to stop those movements, you're gonna rip your hamstring. And it happened a lot of times. So
you feel like the strength workouts are more towards that maintaining and doing the injury prevention side, or do you feel like it's enhancing their performance?
I think both. We definitely started out as a base strength, but now we're getting into more so to actually enhancing and kind of doing like more plyometrics and getting more of those aspects of strength rather than just maintaining it, so they can really excel in the pool. Because they need all kinds of, they need muscle endurance, they need power, they need just base strength, everything. So
Got it. All right. Yeah, I was curious about that. All right. So we definitely went over our time, but yeah, I think that was definitely a great conversation. I was a little, I was definitely did not expect the conversation to go towards anything we talked about as usual, and I'm glad that we got it all organically and talked about everything we wanted to talk about relating to the envelope of function, the physical stress theory, and what we can do better for our respective professions. And I think that's what really comes down to. But yeah, so with that said, what should we talk about next time? What should we talk about in 2 weeks? I know we talked about hamstring avulsions or ACLs. I think those two were mentioned last week. What are you guys' thoughts? What do you guys
Open for anything.
Anything? All right. So let's see. How about I'll just find another article and we can talk about. Let's see. You can talk about. Let's talk about hamstring avulsions. I feel like that's something that's just we don't see that too often, but
Okay.
But just something that I think, Ross, I forgot if you had some presentation.
Yeah, I have that on a PowerPoint. And then, so I think last time I updated it was probably about 2018. So I don't know if there's anything new that we could come up with, if there's another article that's to supplement it in the last like year or so, like between 19 and 20, that'd be great.
Okay.
So cool.
I'll go through the articles because Vian and Ryan, they had like a 3 or 4 part thing on hamstring injuries. I'll go through the articles they sent out and see if there's anything specifically about avulsions.
Perfect.
So we can
Very
do.
cool.
So let's do this. The 2 weeks from now, we'll go through the presentation, and then the next one after that, then we can go through the articles as well, and go from there. So it's more of a discussion type.
Okay.
Sounds good.
That works.
Cool. Thanks for joining on our Think Before We Drink number 4. We'll see you next time. I believe the next date will be the 9th. June 9th. All right, so we'll see you guys on June 9th. Thanks for joining in, and have a great Tuesday. Stay cool.
Peace out.
Thanks for facilitating, Phil.
Thanks, Phil. You the man.
Thanks for joining.
You're the man. You're the man. How can it be man? You're the man.
Okay, bye.
Bye.